negative, actually you still have a very, very little virus still in your body, even though it's PCR negative, because there depends on the cutoff point, the CT value of the PCR. It's only just one number, whether you're 40, you are positive, or 39, you are negative, but still, you know, like you still have that. So I try to avoid as much as I can.
Okay, great. I think Dr. Jayant is about to start.
Okay.
Yeah, we are going to, just one second.
So take Janvi as Janvi is there in attendee.
I'm just looking for
Janvi seems to be joined already.
Janvi is in attendee.
I think Manikandan sir has to join. Just one second. I'm sending the link. Good evening, sir. Yeah, can we start our presentation? Good evening. On behalf of Isfaro, Indian Society for Facial Trauma, Aesthetic and Reconstructive Otolaryngologist, I welcome you all. So far, we have successfully completed facial trauma, reconstructive and rhinoplasty webinar series with tremendous response. Now we welcome you all to the fourth session of Craniofacial webinar series. Today we have the most eminent and notable person in the field of cleft surgery as our speakers. Dr. Nehal Patel. He's a consultant oral and maxillofacial surgeon with a special interest in cleft and TM joint. Dr. Elva from Indonesia. She's currently is an adaptation program of oral and maxillofacial surgery at Universitas Indonesia, Jakarta. Dr. Brajendra Bashir sir. He is a senior rhinoplasty surgeon in India and the director of Akash Nose Clinic. He is the founding secretary of Indian Society of Facial Plastic and Reconstructive Surgery, and he is the Indian head Board of the Directors of Pan Asia Academy of Facioplastic and Reconstructive Surgery. Dr. Manigandan sir is from Chennai, India. Sir is working in Meenakshi Cleft and Craniofacial Center. He's a senior most oral maxillofacial surgeon and well-known facioplastic surgeon in the circle. Welcome, sir. Our moderators are Dr. Rajesh Yadav, our President-elect Isfaro, and Dr. Mohan Jagde, Vice President Isfaro, Dr. Rasu, Dr. Navadeep, Dr. Janavi, she's a consultant ENT surgeon at Janavi Hospital, Mumbai. Welcome you all. Over to Janavi.
Thank you, sir. Good evening, everybody. Welcome back. I'll introduce our first speaker, that is Dr. Nehal Patel. He is a MDS oral maxillofacial surgeon, Mangalore. He's done his fellowship cleft and craniofacial surgery in 2007. He's done his fellowship in TMJ arthroscopy, Austria and Germany. A residency in TMJ arthroscopy and total joint replacement from USA. He is the director of DCKH Cleft Center, Surat. He has been felicitated by German Cleft Children Aid Society for operating 3,000 plus cleft surgeries. He has been awarded the Byton Award in Beyond Dentistry category. He's a pioneer in TMJ arthroscopy in India. He's a faculty in Amrita TMJ course since 2016. Multiple national and international paper presentation, and he's the member of American Society of TMJ Surgeons. Welcome, sir. Over to you.
Thank you, Dr. Janvi, and thank you for inviting me as to deliver a lecture on alveolar bone grafting. So I'll be speaking on alveolar bone grafting in a cleft patient basically, and I'll be covering what type of bone graft we use, the technique and the rationale of the treatment. Now the cleft alveolus, that means the defect which present in the cleft patient between the two part of the segment in the alveolus. So basically, most common variety you see is between the lateral incisor and canine, which is a Tessier 4. Between central and lateral incisor, which is Tessier number 3, and between central and central incisor, which is number 0, which is very uncommon. So this is the main defect you see in a cleft patient after doing a palate and the lip repair. So what are the so why should we attempt to close a alveolar cleft? When should? This is a question we should ask, or these are the questions we have to answer. So when should one attempt to close the alveolar cleft, and how to close? So I'll be covering the rationale of the alveolar bone grafting, the age at which we actually do a bone grafting, timing of orthodontic treatment, type of bone graft and donor, and the technique. So before we go forward, so what are the considerations? So because of the cleft in the alveolus, there will be a nasal, oronasal communication, which can cause a regurgitation of the fluid or food. Then there will be a malformed tooth which may be present inside the alveolar cleft, or malposition lateral incisor. A tooth eruption in this area, deciduous as well as the permanent dentition, may delay because of the cleft alveolus. And so this is the basically scenario of the cleft alveolus. You can see here one lateral incisor which is moved on the palatal side, then the central incisor which is rotated, and there is a defect in the alveolar portion of the alveolar portion. So what is basically rational? So alveolar bone grafting provides a bone for eruption and orthodontic repositioning of the teeth. It provides a better periodontal support for the teeth bordering the cleft. it closes the oronasal fistula and prevents the regurgitation of the fluid. It supports and elevates the alar base because in cleft, usually if you see on the cleft side of the nose is usually on down because of lack of bony support. So it provides a uh, alar base support. It stabilizes the premaxilla in bilateral cases, and it also provides the stability of the maxillary arch and provide continuity of the alveolar ridge. So this is a patient without bone grafting. You can see there is a the base of the ala is gone. It's both of them are asymmetric, and this is the after bone grafting. So it provides the support for the alar base. It closes this oronasal communication. There's a direct communication from the nose to the oral cavity, which can cause a regurgitation of the fluid, and also it fills the defect of the cleft. There are actually two types of bone grafting, primary and secondary. And secondary actually is early and delayed. Primary usually we don't do now because so primary bone grafting is a bone graft is done at the time of primary cheiloplasty or when we do a lip repair. The bone graft which is done during the first 2 years of life and prior to eruption of the primary canine, that is before the eruption of the deciduous canine tooth. It was popular in 1950s and 60s. So it done in conjugation with the maxillary orthopedics, usually with the Latham appliance. The rib graft, which is they used to place either simultaneously or with lip repair or shortly after that. It is abundant due to question about maxillary growth and development. So these are the actual disadvantage. So this data suggests that primary bone grafting has been negative effect on the maxillary growth and nasolabial appearance, and it may necessitate the further bone grafting in childhood due to insufficient alveolar bulk. So because of this, it is largely abandoned, and this is the procedure they used to perform. The rib graft was usually placed between the defect at the time of primary cheiloplasty. Sorry. The second is gingivo periosteoplasty. This is like GBR, so guided bone regeneration, and basically it has to be done with the nasal alveolar molding. So basic idea is to bring the both the segment of the uh, maxillary segment together, and during the primary rib repair, just closure of the periosteum or the gingival periosteum so that it regenerates the bone in this region. When we do a nasolateral molding, this procedure becomes very easy and it can be done during the primary lip repair. The secondary bone grafting is basically what we do, and it is early, intermediate, and late. So early secondary bone grafting is the bone grafting which is done before eruption of the permanent lateral incisor. Usually between the when the lateral incisor is 1/3 or 2/3 is formed, age is 5 to 6, and lateral incisor is frequently hypoplastic. Secondary bone grafting is this is the most common procedure we perform. It's a secondary alveolar bone grafting. Mostly particulate autogenous cancellous bone is used to fill that bone defect, and there is no observed growth disturbances. So it is done before the eruption of permanent canine, that is between the age of 8 to 11. This is the most accepted procedure, and it's predictable production of ample stock of viable bone with the adequate cross-sectional width of the both eruption and orthodontic tooth movement. So this is a bone defect in bilateral cleft, and you can see here the canine is 1/3 form, and this time the bone grafting is usually done. The late secondary bone grafting is when bone grafting is done after eruption of permanent canine. This bone grafting basically is been done to stabilize the maxilla during the adolescence or adulthood. The main purpose of this type of bone grafting is for prosthetic and periodontal rehabilitation. Cannot repair bone loss onto the tooth, and sometimes done in conjugation with the orthognathic surgery when we do the Leafort 1 procedure. So when should we do a orthodontic treatment for this patient? So there are two definite mechanotherapy for the orthodontic treatment. Is pre-secondary bone grafting, that is before we start the bone grafting, and post-secondary bone grafting for alignment of the proper tooth. So pre-secondary bone grafting is basically the preparation of the arch for the bone graft. So the permanent incisors are aligned whenever necessary. The arch expansion is done, and the gap is actually we have to increase the gap so that we can have a good gap to fill that defect with the bone graft. This is an expander which is used for arch expansion. And post secondary bone grafting is usually after 3 to 6 months after bone grafting procedure is done, and once the maxillary segment is stabilized, two of the maxillary segment, and depending on the radiographic image of the area. It is basically to correct the position of the permanent teeth, and this phase involves the movement of the canine through the grafted area so that all the upper teeth is aligned in the proper arch form. So how usually we do is you have to use this is a flap design. There are two thoughts. One is vestibular incision and one is clavicular incision. But it is now proven that the attached gingiva, it provides a protective covering over the tooth and the attached tooth via fiber of the periodontal ligament. So when usually the incision is clavicular incision around the tooth so that when we close the defect, usually the defect is covered with the attached gingiva on the bone graft. So this is a flap design around the defect, allus defect, and on the tooth. So buccal and palatal flap is raised, the defect is open. You can see there is a direct communication. The palatal incision, the buccal flap is elevated superiorly and palatal flap is elevated and pushed posteriorly, and it is closed so that you have to prepare a bed for the bone graft to place. So there is a nasal mucosa and there is a palatal mucosa which is closed, and this is a alveolar bone defect. So bone graft basically there are multiple sites and multiple variations. What we use usually is the autologous bone graft, is a particulate bone graft from the ileum, and medial trap approach for the harvestment of the bone graft is what we use. Is a donor site, can harvest the bone from ilium, rib, chin, calarium, or even sometimes from the tibia. The bone graft is pushed inside the defect, and defect is closed primarily with the active suture. These are few of the pre and post op of the bone grafting procedure. Thank you very much. I think, shall I stop sharing? Thank you for inviting me for this webinar. Thank you, Professor Jain, Dr. Jain.
Thank you. Thank you, Nehal. It was excellent.
Thank you so much, sir. Hello,
Thank
can
you.
you all hear
Thank
me?
you. Yeah. Thank you.
Yeah. Thank you so much, sir. That was really enriching. Can we move on?
Yes.
So, yeah, I'll introduce our next speaker. That is Dr. Elva from Indonesia. Adaptation program of oral and maxillofacial surgery at Universitas Indonesia, Jakarta. Doctor of dental surgeon at Columbia Asia International Hospital, Indonesia. Fellow International College of Dentists, USA. Initiation ceremony at Kuala Lumpur, Malaysia. Clinical fellowship in Craniofacial Center, Department of Plastic and Reconstructive Surgery at Changwing Memorial Hospital, Taiwan. AO Cranio-Maxillofacial International Fellowship, Department of Oral and Maxillofacial Surgery at Peking University of Stomatology, Beijing, China. International Resident in Cleft Lip and Palate Fellowship Program at R.S. Hassan Sadikin Hospital, Bandung, Indonesia. In 2017, Doctor of Philosophy, PhD of Oral and Maxillofacial Surgery at National Yang Ming University, Taiwan. In 2012, Master of Dental Science, MDSC of Oral and Maxillofacial Surgery at National Yang Ming University, Taiwan. 2005, Bachelor of Dental Science, BDS at University of Sumatera Utara, Medan, Indonesia. Welcome, ma'am. Over to you.
Okay, thank you for your introduction, Dr. Janvi. I would like to thank Dr. Giant and Dr. Rasru for the invitation. First of all, I would like to thank my university, Universitas Indonesia, and my department, Oral and Maxillofacial Surgery, for their support during this tumultuous time. Your support is greatly appreciated. Our campus located in Salemba, capital city of Indonesia, Jakarta, and the other one in West Java, Depok. We have 2 hospitals and collaborating with other network hospitals. So if any of you interested to visit, please do not hesitate to contact me or through our website. Not forget to mention my both professor from Taipei Veteran General Hospital in Taiwan. They're encouraging me when things seems impossible, guide and supporting me when no one was there, and they urged me to do clinical fellowship. On the left photo with Professor Tao when I graduated from PhD degree, and on the right, Professor Lei, who taken on this photo taken on the hospital lobby after the meeting with the deans. And then I was accepted in Changkeng Memorial Hospital, Plastic and Reconstructive Surgery, Craniofacial Division. I was lucky because there's a lot of applicants and very grateful during my 2 years of clinical fellowship and palate. My first year was with Professor Philip on the left photo, and the second year was with Professor Low on the right photo. Both of them really opened my knowledge in this field. Besides working with them, they brought me together in their mission trips and giving me a chance to join several meetings to present their techniques. Last, Professor Irachen, he's currently honorary chairman of Changkeng Steering Committee, an expert in OGS and facelift. I want to specifically thank to him for taking the time to discuss my professional options with me. For all of this, thanks to my wonderful teachers. Thank you for providing me with all the knowledge and moral support I need. As I mentioned previously, both of them, Professor Philip and Professor Low, are an expert in cleft lip and palate. This was during our morning meeting with Professor Philip every Friday. Our discussion was a girl with cleft lip and palate from Africa. For further details, please watch YouTube link I posted below. Lucky to be involved in the lip repair treatment for the African girl. This was the African patient transformation from complete bilateral cleft palate to incomplete, and this is the final result. On my second year with Professor Low, we had research meeting and cases discussion on every Tuesday. As you can see in the laptop display, I was trying the prototype of 3D parallel guide for implant placement. This is what was me with Professor Low team after finished performing cleft OGS. This patient came to us after 3 times failure for lip repair, and what Professor Low did to achieve the nice outcome, it will be discussed later on. In this lecture, I only discuss about cleft lip and palate revision without including secondary rhinoplasty and ABG. So what is the goal of reconstruction and revision surgery? Is to restore functionality and symmetry to the lip. The incidence of secondary lip surgery is varied with more recent articles quoting a rate from 16 to 56.9%. Thus, the secondary surgery needed is often based on surgeon, patients, and or for family preference. Currently, no clear indication exists on the type or method of revision required when it is best performed. But common reason for revision include pore scarring, like widening or asymmetric philtrum and etc. And as a surgeon, patient concerns and desires, as well as age, should also be considered prior to this revision surgery. There is a new classification for secondary cleft lip deformities, which developed by CETA. In general, the patient divided into two groups on the basis of their deformity. For the group 1 is superficial deformity, which include pore scarring, familial border, and so on, which these can only be treated with minor revision of the skin and or mucosa. And for the muscle deformities, which include in a vertical short lip or filtral asymmetry and so on, can be treated with a total repair of the cleft lip. In this group 1, we have the superficial deformities. These techniques generally are used to address pore scarring. You can see hypertrophic scar, you can use topical mediator, silicone gel seating. Some use CO2 laser, scar texture and appearance. You can use autologous fat and the dry wet lip junction, severe nasal deformity, minor scar, vermilion. You can read on their paper. For the second group, the muscle deformities for the unilateral cleft lip, usually with muscle-related deformities, require revision, often necessitating complete lip redo. In unilateral, you can see alar-based asymmetry. You can use modified rotation. We have filtral column reconstruction. For the bilateral, you have narrowing the prolabial width. You can use modified multicam, even major dehiscence and complete dehiscence with premaxilla and downward. Thanks to my friend, a plastic surgeon from Singapore General Hospital, Dr. Politan, for inviting me to join their mission trip to Hainan, China, and Professor Emeritus Lee, who entrusted this responsibility to me. On the bottom left, a group photo with the anesthesiologist. This is the case of a patient with superficial deformities. You can see here a straight columellar, slightly depressed alar, and then nasal seal, quite acceptable scar, and it is scarring on the vermilion and white skin roll. This is the other angle of the pictures, photos. And then this is how the incision looks like. We use a triangle flap and we wedges. And then how it looks like, we have this very smooth vermilion, and this is the other pictures. Next is for the muscle deformities. We can see a slightly deviated columellar, slightly depressed alar. We have these muscle deformities. You have wide nostril, two segments of this vermilion. We have these scarring, and then you see deficiency of the mucosa. This is how the incision looks like. Then you can see we gain this nostril height. We have the nasal seal, reconstruction of the muscle, orbicularis muscle, smooth vermilion. We have this quite a smaller nostril compared to the other side. Smooth vermilion, a fullness of the mucosa. And this is a post-op, 3 days after post-op. You can see here, it actually is not the deficiency of mucosa, but it's the protruded of the tooth. So we suggested the patient to take out the tooth for more aesthetic outcomes. So in some patients, it can be difficult to achieve satisfactory functional and aesthetic results, especially those with inadequate soft tissue. For example, a patient with a tight upper lip, maybe absent of Cupid's bow. This AB flap proven very versatile for the reconstruction of severe secondary cleft lip deformities. I show a little bit. This is a triangular flap was designed on the central portion of the lower lip. The width and the length of the flap were proportional to that of an anatomical normal vitrum. And then a full thickness incision through skin, muscle, and mucosa was made in the midline of the upper lip to divide it into 2 segments and create a recipient site. The epiflap based on the left inferior labial artery was elevated and converted into an island flap by cutting the mucosa entirely, leaving only a cuff of muscle around the vascular pedicle. Then the flap was then transposed and placed into the recipient side in the upper lip and sutured to the lateral segments of the upper lip. A bolster transfixation suture is placed contralateral to pedicle to prevent accidental opening of mouth. After a week, the pedicle was divided and the insert of the flap was completed. We can see here, this is a pre-operative and post-AB flap. We can see that there is a bulk of tissue in upper lip is expanded, and we have this eliminating the tightness and providing lengthening of lip. On the figure 2, you can see that both have excellent orbicularis oris function. This is another case. We have this female patient was sent to our center after failed BCR repair. At the time of evaluation, the essence was found on both sides of upper lip and nostril floor, and the remaining prolabial tissue was insufficient. Decision was made to postpone the lip reconstruction. And then reconstruction of the lip repair using an AB flap for continuation of muscle reconstruction, and closure of nostril floor was performed at 4 years of age. And then the central scar tissue were excised and replaced with the lower lip full thickness of tissue. The operation was successful and division was done in 2 weeks. She subsequently received surgery of alveolar bone grafting at 9 years of age, 2 jaw orthodontic surgery at 16 years of age, and lip nose revision at 18 years of age. The overall final result were satisfactory. Next, there is a modified AB flap. This design was made differently in terms of shape and location according to the diagnosis of the patient, whether it was bilateral or unilateral cases. For unilateral cases, you can use this proper recipient space was made as equal size of flap, sorry, which being a same length of normal vermilion border line, including remaining length. For the bilateral case, you can see they use a pentagonal shape flap was designed. And then you can see figure number 2, C and D before, oops, sorry. Okay, and then you can see this on the figure 2, C and D, it's before AB flap and 2 years after flap transfer, including open rhinoplasty and 2 stage of scar revision. And then this is the preoperative and post-operative appearance, 2 years of lip protrusion and profile. So for mucosa deficiency, we have this B-wing myomucosal switch flap. This is the illustration. Upper and lower lip incision line were marked, and the lateral view of the flap dissection on the right side of the pictures. Then the upper lip recipient side was dissected after releasing incision. The lower lip elevation of the B-wing myomucosal switch flap showing the wings and central pedicle is shown. On the right picture, the donor side was closed primarily, and the flap was transferred and inserted to the upper lip and sutured. Then pedicle divided at 14 days later. This is a patient of 18 years old, female patient with bilateral cleft lip and nasal deformity. She had a relative short upper lip and lack of lip projection. The vermilion was thin and then with no central tubercle fullness. The lower lip was protruding. Then the patient underwent simultaneous B-wing myomucosal switch flap and rhinoplasty. At 14th month after surgery, the patient shows improvement of the lip profile and vermilion balance. What about for the more complicated lip repair, where you have to use vomal osteotomy and with bilateral lip repair? This is the patient of 9-year-old patient with bilateral cleft lip palate, was referred to us from a non-government organization operating in a neighboring country. It was reported that he had received 4 times of surgery for his cleft since he was 2 years old. Lip wound descent was noted 3 times after each surgery, and the findings show complete descent of the left side of lip, absence of the prolabium, then severe tissue scarring and a descending and a protruding maxilla for almost 12 millimeters from the lateral maxillary segment. There were severe dental caries, and then intraoral evolution revealed a repair palate with multiple oronasal fistula. He was admitted 1 week before the surgery for this supply for the nutrition, and after team discussion, a treatment plan was made to perform premaxillary position and simultaneous lip repair. An occlusal plane was fabricated for the intrusion and setback location of these premaxilla. So during the surgery, the teeth with severe caries were extracted. Then vomal osteotomy was performed. The premaxilla was repositioned and fixed with K-wires. Rotation advancement type of lip repair was performed for approximation of the lip segments with no prolabial tissue for reconstruction of philtrum and Cupid's bow. Secure muscle sutures were achieved. Tajima method was used on both sides of nostril dome for repositioning lower lateral cartilage. The surgery and post-operative recovery was smooth, and he went back to his country in 3 weeks. He was monitored by a local team and was reported to be well. The K-wires were removed in 3 months, and the premaxilla was stable. The local care provider sent back the photo showing a nice lip healing and acceptable nose. And this is the picture after 3 years. So how about lip augmentation? These include autologous fat grafting into various components of lip for volume and symmetry. You can use dermal fat and or filler. Timing of lip revision. Superficial revision can be performed during growth, particularly if these help in socialization and are at the patient's request. And complete redo lip revision are often postponed until the end of growth unless requested by the patient. And in some patients can be combined with septorhinoplasty. And of course, the surgeon's primary role is one of the information provider, discuss what is possible and what can be done to patient and family. Of course, let the patient to make their own decision. There is a lot of unsatisfactory outcomes of cleft palate repair, include oronasal fistula and persistent velopharyngeal dysfunctions, which are among the most common indication for revision surgery. Fistula occurs after wound descent, which can be secondary to closure under tension or infection and so on. And several studies attribute fistula to these patient factors, for example, age at primary repair, presence of syndromic condition, and so on. And surgeon experience and technical aspect also as a potential causes for the failure. Numerous techniques have been proposed that claim to decrease the incidence of oronasal fistula, for example, like modification of fulopalatoplasty, fibrin tissue sealant, and so on. And also there is a multiple interposition graft, such as a gel form, and you can use cartilage, a bone, and so on. The incidence of oronasal fistula after primary cleft palate repair has been reported to range from less than 1% to upward of 76%, with an average of 8.6%. And this is a proposed system from the Pittsburgh fistula classification. What about the management of clinical assessment? We can use nasopharyngoscope to allow see the clear inspection of the fistula with simple illumination, as well as evaluation of soft palate mobility and competency of the phalangeal closure. To determine its effect on speech, the fistula can be temporarily occluded using a dental wax or a palatal plate. If hypernasality diminish, the etiology of speech dysfunction can be attributed to the fistula, and a period of speech therapy is likely necessary after closure. On the other hand, if the hypernasality persists, additionally, phalangeal surgery may be needed. Fistula may become clinically significant when they lead to nasal air escape or speech distortion. Even a very small fistula, measuring 1 to 2 millimeter, can cause air leakage and speech impairment. For patients with a normal phalangeal mechanism, repair can be performed at any age. The closure of the fistula should be delayed if possible until completion of orthodontic maxillary arch. For patients with inadequate phalangeal function, a nasopharyngoscope or examination and a fistula occlusion test is performed. If improvement is noted, closure of the fistula alone can be performed. In patients with no improvement, a simultaneous phalangeal surgical procedure can be considered. So this is an algorithm for the management of oral nasal fistula based on location. They all have these for example, like pharyngeal flap, full of palatoplasty, and then they have combining pharyngeal flap with full of palatoplasty. But if its fistula is more than 40 millimeters, they use obturator or this free flap. In a larger palatal fistula, healthy vascularized tissue from other donor site is preferable. These include Guerrero Santos and Altamiro's tongue flap. More recently, the buccal fat pad flap also been advocated for closure of larger hard palate fistulas because this flap is mobile and can easily reach the midline or the lingual central incisors. For full double opposing C plasty, you can close a fistula or for the VPI. In this paper, they show the palatal motion after primary and secondary full palatoplasty. Often during secondary full palatoplasty, one does not encounter a truly transverse orientation of muscle fibers, rather an orientation similar to the sagittal alignment observed during repair of submucous cleft palate. During palatal repair of such cases, full-palatoplasty reorients the muscles in a proper transfer position, but does not overcorrect a more posterior position than a transverse. There we can also use a pharyngeal flap. They have a superior and inferior base of pharyngeal flap. For superior base pharyngeal flap was raised from the posterior pharyngeal, the donor side was closed. The soft palate was split hard palate. The pharyngeal flap was transposed and inset into the fist mouth and fixed. The tip of the uvula was sutured backward to partially cover the raw surface of the flap pedicle. For inferior base pharyngeal flap was raised from the adenoid area of nasopharynx. The donor side was left opened. The pharyngeal flap was turned anteriorly over the soft palate. A distally based palatal mucosa flap of a similar size of the pharyngeal flap was raised and turned over to cover the raw surface of the pharyngeal flap pedicle. So in their results, inferior base pharyngeal flap provided a better outcome after phalangeal surgery. Why not superior base pharyngeal flap? But the superior pharyngeal flap technically easier to raise and longer flap is available. So the reason is because using the fist mouth method means exposed, and consequently it has this tubing phenomenon, and shrinkage may impair the phalangeal closure function caused by inadequate blood perfusion, and biopsy of the flap show only scar and no muscle component. So this scar contracture of the row surface area flap tends to bring the pedicle and the soft palate in a downward direction, which may also perturb the phalangeal closure. To achieve this, the row surface of a pharyngeal flap should be in order to cover the surface, we modified this fullopatoplasty with pharyngeal flap for management of phalangeal insufficiency. So the modified fullopatoplasties begin with an initial Z incisions on the soft palate. Then the anterior base of oral mucosal flap is elevated on the right side. Then posterior base oromuscular flap is elevated on the left side. The soft palate is split in the midline by true and true dissection, and 5 millimeter margins of nasal mucosa is reserved at the hard palate junction. And the nasal lining is incised oblique from the midline in different directions, and the superiorly based pharyngeal flap is raised from the posterior pharyngeal flap. Then the pharyngeal flap is inserted and sutured to the nasal lining at the central posterior margin of the nasal side. Then the nasal mucosa is trimmed and adjusted to facilitate better wound closure with the lateral pharyngeal flap. Nasal catheters are passed down through bilaterally until they meet at the midline of the pharyngeal flap base. Below that point, the nasal mucosa is sutured to the margin of the posterior pharyngeal wall to form a tube-like portal opening bilaterally. Then the levator muscle is oriented and sutured in the transverse plane. Finally, the oral mucosal flap is sutured to the corresponding mucosa to complete the wound closure. In conclusion, cleft lid and palate revision should only be considered in concert with the patient, be based on the patient's concerns and desires, and offered at the appropriate timeline to improve social integration and or psychosocial well-being. For the clinical assessment for each patient should include, for the lip, you have to see the analysis of the nasolabial appearance at rest and during function to correctly diagnose the problem. And for the palate revision, you have to know the size of the fistula, and the VPI depends on the closing ratio. This is the group pictures for these 40 years of anniversary at Changke Memorial Hospital. We have this from this craniofacial division. Thank you.
Hello. Thank you, ma'am. Thank you so much. That is really, really enlightening, and I cannot say much. Can I go on to the next speaker? Hello. Hello. Yeah. Can I go on to the next speaker? Yeah. So our next speaker is Dr. Brajendra Basir from India. He's a cleft rhinoplasty surgeon. Dr. Basir is a senior rhinoplasty surgeon in India and director of Akash Nose Clinic. He is the founding secretary of the Indian Society of Facial Plastic and Reconstructive Surgery. He is the India head board of directors of the Pan Asia Academy of Facial Plastic and Reconstructive Surgery. He is honorary consultant, Cheslow Hospital and Research Center, Mumbai. He is the head professor of Sri Aurobindo Institute of Medical Sciences, Indore. He is honorary consultant at Chodram Hospital and Research Center, Indore. He has 3 books that are used as textbooks for rhinoplasty in 20 countries. He conducts training courses for ENT, plastic surgeons, and maxillofacial surgeons since 2000, and over 1,200 doctors from all over the world have attended his courses on rhinoplasty. He has published a book on aesthetic and functional rhinoplasty. He has published over 40 original research papers in various national and international journals and has contributed chapters in several books, invited speakers for various national and international conferences and workshops. Welcome, sir. Over to you.
Thank you very much. Thank you for the kind introduction. And
The noise is from...
And thanks to Dr. Can you hear me, Jayant?
Yeah, it's
Hello?
very
Yeah.
yes.
And thank you very much to Jayant for inviting me here. And I always admire the wonderful work he is doing. And today I'll be sharing some of my thoughts about unilateral cleft nose deformity. Now, this is more of a practical lecture than didactic lecture. So I'll be sharing my experience rather than a review of literature and things. And where is the... So these are the hospitals where I work, the Akash Hospital in Indore and Jaslok Hospital in Mumbai. Cleft lip nose deformity results in a complex three-dimensional facial deformity, which leads to poor functional, aesthetic, and social outcomes.
Rajendra sir.
Yeah.
I think you are not sharing your screen so far. We can only see you. So you have to share the screen as well.
Just a minute. I think I shared. Mm-hmm. Is it?
Yeah. So you have to open your presentation, sir. We can see your desktop. Yeah, now it's coming.
Yeah. Okay. So, right. Is it okay now? You can hear me and see my screen?
Yes, sir.
Yeah.
Yeah, definitely.
Cleft lip deformity results in a complex three-dimensional facial deformity, which leads to poor functional, aesthetic, and social outcomes. The annual incidence of cleft lip palate is deformity is 28,600, which means 3 infants with clefts are born every hour. And with the most common cleft pattern being left complete cleft and palate. Patients with cleft deformity have cosmetic problems and impaired nasal airflow as a result of distorted anatomy. These patients may have septal deflections in addition to the cosmetic deformities, atretic nostrils, and turbinate hypertrophy. Now, this nasal deformity offers a unique challenge to the reconstructive surgeons. And by the time these patients come to us, almost, I said, most of them, they had 1, 2, or 3 previous surgeries. And that makes the job more difficult. The clinical presentation of cleft lip varies widely, requiring a host of surgical techniques. There are many techniques to deal with cleft lip nose, as I said earlier, but I will be sharing what we are practicing and we found it useful in our clinical practice. Deformity may be quite severely asymmetric, and because you have a wide spectrum of deformities, which can range from severely asymmetric, and that makes surgical correction difficult. Patients with cleft lip may have been previously subjected to numerous surgical interventions. Timings of rhinoplasty, whether synchronous or staged with cleft lip repair, is controversial, but now I think the controversy is settling down and most people prefer to do early intervention. The nasal anatomy in pediatric patients may affect the growth, but now we have long-term series available and which says that it can be performed without much of the problems. And these are some of the primary nasal surgery at the time of cleft repair. Now, just relevant anatomy. The major defect of cleft lip nasal deformity concerns the position of the ala. The ala lies inferior and lateral to the contralateral side. So we have an imbalance in the two sides. On one side, it looks lower down because of its relative position and looks more lengthy. The ala rests on underdeveloped premaxilla. Though most of the patients which are coming to us, they already had a bone grafting to us, but still the premaxilla is underdeveloped and may require a graft at the ala base, and which accounts for ala base lowering and horizontal nostril seating. So this is the typical cleft lip nose deformity who has undergone successful lip surgery, but they come as usually in the adolescent age, and you can see there is alar deformity, columnar deformity, dorsal deformity, nasal airway problems, and septal deformities. And surgical corrections aims at establishing a patent nasal airway while creating a more favorable external nasal appearance. So we have to look after for both parts, aesthetic as well as functional. Now, what are the areas of concern for surgeon? Rhinoplasty in patients with cleft lip associated nasal deformity poses an imminent reconstructive challenge for the surgeon. There are 2 areas of concerns: the nasal structural framework and the soft tissue envelope. So you have to take care of both parts. Pathological anatomy: nasal tip, alar cartilage, and columella. Lateral bony platform, parimaperture, midline supporting structures, cartilaginous septum, and anterior nasal spine. So we have to achieve a balance on the both sides, the cleft side and non-cleft side, in these three parts. So this is a typical presentation of unilateral cleft nose deformity, and you can see out while the ala on the non-cleft side is well developed. You have the middle crust, the medial crust, and the lateral crust. While on the cleft side, the cartilage is not well formed, the middle crust is absent, the columella is white, and the insertions are at different levels. So this gives an appearance of a typical cleft nose. Now, surgical techniques. The techniques which we use, obviously, in most of these cases, we use open approach, which can be done by inverted V, or I used stair-step incision with intracartilage extensions. Nasal skin and substitution envelope is elevated, and the structural deformity is visualized and assessed. The nasal septum is approached by a sharp dissection between the medial crura of the two lateral cartilages. The caudal septum is visualized between these two cartilages, and a submucopericordial plane is identified and dissection is continued in the correct plane. A portion of the septal cartilage. Now, it is surprising that there is in many of these patients you have a good amount of septal cartilage, which can be a very useful graft, but many people straightway jump to the rib cartilage and do not use this cartilage, which is available and which is a very useful source of graft material. But at the same time, if there has been previous attempt at rhinoplasty and there is excessive scarring and fibrosis, I mean, it's better that not to dissect, otherwise you may end up in perforating the mucopericordium and causing septal perforations. Now, technique for reconstructing the deficient cleft side. The upper lateral cartilage on the cleft side is separated. I will be showing you these steps on the actual patients to make a better understanding. But the philosophy is that to mesh the two sides, you want to mesh the non-cleft side with the cleft side. Now, there is a deficiency in three parts: the nasal bones, the bony vault, the cartilaginous vault, and the lower cartilaginous vault. So the upper cartilage on the cleft side is separated from the dorsal septum while preserving the underlying mucopericordium. Now it's only on the cleft side we are separating it, and not on the non-cleft side. Paramedian osteotomies and medial osteotomy is done with the help of a piezotome saw for precision. So you do a paramedial osteotomy, a transfer osteotomy, and a lateral osteotomy by percutaneous osteotomy. So this segment of the combination of paramedian, transverse, and lateral osteotomy helps in mobilizing the lateral nasal wall on the cleft side. So the lateral nasal wall on the cleft side is completely mobilized by a combination of this osteotomy and separating the upper lateral cartilage from the dorsal septum. The mobilized lateral wall is then elevated and moved upward and outward laterally at the same level as the normal side. Now, when it is completely mobile, and if moves laterally, this can also come down back again to the normal position. So to stabilize it in the lateralized position, we use a long spreader graft. Rib cartilage or septal cartilage is used, which extends up to the nasal bones. So it pushes the the cleft side nasal framework laterally and keeps the mobilized lateral wall in an elevated position. Correction of low lateral cartilage deformity in the nasal tip. This is the most controversial part, and the literature is full of n number of techniques with the good results and what is good for you. But I am trying to simplify it for the beginners and those who are not frequent cleft surgeons. A few studies suggest that the length of the lower cartilage on the cleft side is equal to non-cleft side, differing primarily in shape and position. I mean, that's true in many cases, but most of the time this cartilage is weak. The medial crust is shorter and the lateral crust longer on the cleft side, and the angle between them is obtuse, resulting in a less defined and wider dome. The lower lateral cartilage is completely separated from the vestibular skin and then released from its attachment to the piriform ligament. Well, I'll show you in cases what I mean by this. At times, the cartilage is too wide and a cephalic trimming or infolding of the cephalic part of the alar cartilage may be required. The lateral crust is mobilized medially to create a new dome. So we are doing a lateral curl still where a significant part of the lateral crest is mobilized medially and equal to the non-cleft side to make achieve a symmetry uh, on as to the non-cleft side. The two domes are then sutured together by inverting metal suture using a 50 PDS. This reconstitutes the dome into a more cephalic position. An autologous septal cartilage or rib cartilage slice is used as a batten graft. Now we have done a lateral crural steel. So a major part of the lateral crest has been incorporated in making the dome and the medial crest. So obviously there is a deficiency of the lateral crest, and this is supplemented by autologous septal cartilage. If is available, it is good, or slice of the rib cartilage. And as a batten graft, this batten graft is carved in shape of an arch and made to rest on the pariform aperture, so that it can provide a stable support to the cleft side. Many times you need to use uh, a cartilage graft by a separate step incision below this on the cleft side ala to elevate it and give it the illusion of a in a higher position. Now let's see a case example. This is a typical unilateral cleft lip nose deformity, and this is how we mobilize the separated from the upper lateral cartilage, the paramedian osteotomies, transverse osteotomy, and lateral osteotomies, and see out when I'm pushing it out with the elevator, the whole of the segment can be pushed up. And here is the rib cartilage graft, which is extending, pushing to the nasal bones, and the upper lateral cartilage means the whole of the heminose towards laterally, and alar batten graft, which is used, and this is guided through a suture where you want to put it so that it doesn't go in the right direction and give the results you want to produce. So this is the on table results, and you can see out it looks much better, and the cleft side has been elevated and it's more symmetrical to the normal side. And these are the pictures a few months later, and you can see out this leaves a more natural nose and a significant improvement in the shape. And now I have not used any kind of onlay graft in this patient. All grafts are buried inside the skeleton, and that helps in achieving more natural results. Now, most difficult part, as Mohan said, it's easier to operate but difficult to get results. I mean, that's true for all rhinoplasties, but especially for cleft side. And the most difficult results to get is in the frontal view. In the front, you might get a good profile view or three-quarters view, and you find that in frontal view there is always this ghost of asymmetry remains. To improve out this is a difficult task. This is in the three-quarter view, and this is profile view, other side, and this is the basal view. It's well held. I mean, you can't expect a perfect normal in the cleft patient, but this is a significant improvement from the pre-op appearance. Another case, this was had a revision case operated elsewhere, but this was a very difficult case because a very good looking girl, and she has a special concern that the cleft side of the nose is looking asymmetric, and that gives not so good feeling to it. So here, and because she has a very thin skin, so we wanted to avoid any kind of onlay grafts. So we separated the septal mucoperichondrium along with the upper lateral cartilage to one of the sides, osteotomies, and this is the septal extension graft, and this is the rib cartilage which has been pushed the nasal bones to one side, and a slice of the rib cartilage used in the arch patient as a batten graft to the alar cartilage. The previous steps I already described you in the last case, and this is how the recreating normal anatomy on the cleft side. So we have not done anything on the non-cleft side, and this is fixed in position. I use a guiding suture so that I can take it to the place where I want it to be and doesn't uh, go shift to another place. So, and this is the results on the table, and these are the results several months later, and you can see out the improvement in the on the non-cleft side, which is achieving more symmetrical. The tip has been rotated, especially the tip angle has been rotated, and this is looks more natural appearance with no visible graft from the skin. These are the, you can see out, which is a significant improvement in the frontal view as well. another on the other side, another view, close up. Now, case this patient traveled long way from Bangladesh, and she was operated twice in southern India, and the parents were very unhappy with the appearance of her nose. And she is, by the way, she was a dentist. She is a dentist means. And here we did the medial transverse and lateral ostomies on the cleft side. The heminose is lateralized, and again the rib cartilage was used to push the heminose to at a higher position so that it looks more symmetrical to the non-cleft side. And these are the alar batten graft to extend the lateral crust, because the lateral crust has been used for creating the new domes, and we want to make the new alar. And these are the results you can see on the table. On the sill part has been, a skin part of the sill has been excised, and a small graft has been kept below the left alar. And you can see how the significant improvement in the shape. And these are the results in the table. And she is, of course, from Bangladesh, can't come for follow-up, but she wrote to me that she's doing well, and the parents are happy with that. Another case is again operated twice and very significant asymmetry, operated by the similar techniques, and these are the results about a year later. And you can see out the whole stigma of cleft has been taken away, and it looks much more normal. And this only complaint is now this mustache. So I asked him to go a hair transplant in this scarred area of the lip, but on the whole, it looks much more presentable. And these are the basal views. Another patient with the similar techniques, and none of these patients had an onlay graft. All grafts buried inside the section. Another patient. So these are some of the way I do cleft rhinoplasty. Of course, there are variations, and we need to change the technique and adapt to the particular situations. But the concept that if one side heminose is normal, do not disturb it. When you do osteotomies on both the sides, mobilize the whole pyramid, the whole things get shifted to one of the sides. But if there is a firm one side is nose is firmly present there, and then there is a lateralizing graft, and then you recreate the lower alar, the tip part, the alar cartilage, and that helps in achieving a symmetry and a better looking result in these patients who are not so lucky to be born with the cleft lip. Now, many of these patients had a functional problem. When there is a caudal septal deviation, how do you correct them? Because it's not only important to have a nice look, but also have a breathing nose. And now some of the patients have a small dorsal humps which needs to be rasped. I mean, this besides the septal deviation. But septal deviation, how we correct it, just in this thing, that this is a, yeah, right. That we have mobilized the whole of the caudal septum, both the side, used ethmoid batten graft, and that has been fixed with the spine, and that's how we're able to correct the septum with these things. And yes, the point I forgot to mention is that I used, if the septum is not sufficient, we use septal excision graft in all these cases, which provides a firm, stable pillar on which you reconstruct your tip, because without a firm support, the Allah will not stand in the place. This is a little different from the traditional practice, but we've been using it for many years and found good results. Thank you very much. These are my books on rhinoplasty. And once again, thanks, Jan, for inviting me. It's a short lecture, but I don't want to go didactic on the.
Thank you, sir. It was an excellent presentation, sir, as usual.
Hello. Thank you, sir. That was really great. Can I move on to the next speaker?
Yep.
Yeah. So our next speaker is Dr. Manikandan from India, cleft-related complications. He's a professor. Professor Dr. Mandikaran is working at Meenakshi Cleft and Craniofacial Center. Is a senior oral and maxillofacial and facial plastic surgeon He completed his training from A.D. Shetty Dental College and Hospital in Mangalore, 1992. Since then, he was personally involved with facial, plastic, and reconstructive surgery. He was trained in advanced maxillofacial surgery in UP and completed his fellowship, FPSRCS and FFDRCS in 1996 and 1998, respectively. After his return to India and Chennai, he founded the Cleft and Craniofacial Center while working at Meenakshi Ammal Dental College and General Hospital. He has highly specialized skills in orthognathmic surgery, facial plastic surgery, stem cell and regenerative medicine, trauma reconstruction, and subcranial facial deformity correction. Welcome, sir. Over to you.
Thank you. Can you see my screen?
Yes, sir.
Yes, sir.
Okay. So let me just, first of all, thank you, the team of organizing committee, for asking me to share the bad part of the surgery, that's the complications, okay? But very important that if you operate, you'll get complication. There is nothing like, you cannot get complication with, it doesn't matter, whatever the surgery you do it, you'll get complications. I'm just putting only some here, not everything, but you've seen these pictures probably already been discussed, that a patient with a cleft lip and palate tissue, and you can see that what happens at the start of the procedure, about day 3, it looks very clean and neat. Okay, we have closed very well. But maybe because of these factors like nasal secretions and post discharge and so many things, because you can have maintenance of these things is very difficult. You can have a lot of dehiscence. And this may end up in having issues with post-operative scar and other things, which may definitely require second stage surgeries in a later date. So beware of that, the tension, what probably one might get it when you are operating in a case like this, where the premaxilla is placed in a very high level, and you do not know how far you can really mobilize the muscles and bring back the premaxilla backward without breaking it. And sometimes it's quite difficult to do this as well. And that will produce a lot of tension like this. Probably with the tension, ischemia of the skin edges, and maybe a little bit of infection there, you can get quite a bad, situations. And this is what happened at the day of 20, that it is holding on, probably at the level of the vermilion and everything. But I'm sure that this baby will have a lot of scar when he grows up. Though there is some amount of tissues are maintained. You can see my hair as well. So this is one of the problems, that complications associated with cleft lip, specifically in bilateral and a wide unilateral cleft lip, the tension, what is happening with it. There are so many reasons you can say. I already told you the wide gap, the premaxilla is too high forward, and also very important that you have to follow what is called as a tensionless closure. Infection control is very important. When I say infection control, post-operative is very, very important. Okay, sometimes it is very easy that you have so many patients in the ward. The assistant doctor, or probably ourselves, we will handle patients in a different way, and you have to maintain that the cleanliness of the hand for dressings and so many things like that. And you can also reduce this problem having a very good muscle closure, muscle sling suture between the left and right lateral segment. And I've seen many times that after operation, it's not unusual. When you have a baby, the baby will not, probably after one day, they will probably be there. On the second day to onwards, the 7th day, the patient will be more or less sitting on the floor and sitting, picking this up and picking that up, and touching everywhere. And it's very easy to get infections in such a scenario. So one have to be very careful when you are doing it. It's already been discussed, from the alveolus point of view. I just put this slide just to show you, if you are doing if you look at this boy, it looks nice. The lip is done wonderfully well, with whatever the technique we follow, the modified Millar technique. It looks wonderfully well. But then sometimes during this cleft lip closure, if you are not closing the oronasal fistula proper, oronasal area properly, you might end up in getting a fistula like that. So that is one complication one can expect from cleft lip surgery, which is very, very important to understand. So this is probably because of two reasons. Number one, failure to address the nasal part, a very good nasal closure during cleft lip surgery. Number two, when you have a wide cleft lip, the two periosteal mucosal flaps may not be able to reach each other, and they will end up in having a oro-nasal communication. Okay, just to show you that. Look at this patient. I just operated about 3-4 days ago, in fact. Look at the lateral lip, which is a non-side bilateral, and look at the prolabium. Where is it there? It's like climbing an Everest from there to here, and having no tension at all. It's going to be a very, very tough job. So we might end up in having definite tension and other things, what probably likely to happen. You can see in this slide as well. Look at the lateral areas and look at the prolabium there. Because of this, absolutely, the patient was just turned up without any pre-alveolar molding, and nothing was there. So they just turned up, and I took a CT scan because the patient also had a hypertelorism, just to see whether there is any other abnormality in the skull, brain, and everything. And you can see that the premaxilla is like a separate appendage, which is much away from the remaining maxilla. And I'm sure that one can expect a lot of problem with operating in such things. So in order to reduce the complication, what we have done is that actually we have done to start with some premaxillary osteotomy, okay? Then put a pin to the remaining premaxillary, the area of the vomer, and fix it and bring it down first. Then we go into the second stage, to reduce the complication strategy effect postoperatively. Just to put you that what all the problems you can get it with it. It's been already discussed during the my colleague who had actually just spoke about it. And when you don't have, if there is no proper bilateral cleft lip operation done, you will end up in having a notch, something like this. Very likely you have a midline notch. This notch, what you see in the prolabial area, sometimes it is worrisome, because one of the problems with cleft lip is that the thickness of the upper lip and the prolabium, which may be very, very small. And you'll end up in getting some deficient prolabium with thickness, and you'll end up in having issues of, having cosmetic issues. So this is a long term. So normally one can always do, like already been explained, an abase flap. Okay, so what you see here is the design, and what you see here is at the day of 21, that both upper lip and lower lip have been. I'm just trying to tell you that what all the issues complications can get from this thing. Something like this, sometimes if you are not very careful, patient can have a lot of trouble in, issues in eating and everything. And this is immediately after the revision is done after 21 days. And this is, I think if I remember, about a month after that. So, if we see it, we can get a good thickness and bulk and everything. So from there, as a complication of bilateral cleft lip with revision, you can probably bring it there. So these are the some of things which can happens with cleft lip. If you look at this chap, I intentionally put this case is that here is that. This is one case where a child had a cleft lip, cleft palate, and operated about 4 or 5 times. Okay, and you can see there's a severe because it may be because that I saw this gentleman when he was around 19, maybe because of severe radical dissection of the lip, palate, too many surgeries, which will not allow the maxilla to come forward. It will not allow the maxillary zygoma to come forward. It will not allow the orbit to come forward, specifically when you are stripping the periosteum in a great extent for cleft lip, then you will end up in having trouble with that. So you can get as one of the complications of very radical cleft lip and palate and revision surgeries are that you can expect a severe hyperplasia of the maxilla. So that is one other complication. When it comes to cleft palate, okay, baby was operated at the age of 1 month. Very wide cleft palate, very wide. Okay, we get in Indian subcontinent very wide cleft palate, both in terms of width as well as the total length of it. It is a big problem. Okay, and I'm sure that maybe because of reasons of ischemia and tension of the closure and everything, you can expect some amount of fistula like this, which is very, very large. And it's very, very difficult in a baby to correct this because you hardly end up in having any mucosa left behind to move it directly again. Fortunately, there is some amount of posterior band is being retained. But otherwise, in the anterior area, one have to be very, very careful. If you have a wide cleft palate and you're trying to move, and when you're trying to move, there could be a chance that the pedicle is compromised. And when the pedicle is compromised, you end up in having difficulties, something like this. And ischemia can lead to the flap failure, and fistulas are very, very common with it. So that is another problem with it. And you can see, a case of a revision rhinoplasty. I think if it's the same case, if I remember very well, that, we tried to move in, but you see, look at the amount of secondary defect, what is there. In the center, it looked like nothing is there. So you have to have so many types of revision surgery, so many types of buccal flap raised in order to close this area of ischemia. The more surgery you perform in the palate, and the more secondary mucosa you create, they will be only scar. You don't get a normal mucosa back. And all scarred palatal mucosa, whatever you trace this side and that side, all will end up in problem with it. So all these issues you can expect with patients. Sometimes if it is not anterior, posteriorly you can have what is called as a big velopharyngeal incompetence. We already had a discussion on that. I'm just completing it. So now the velopharyngeal incompetence is a big problem in our country as well, because of two reasons I already told you. One is the wide cleft. Number two, the reason is that the length of the cleft. It has been proved beyond doubt in South America and the Indian continent. The length is always a problem in our cleft palate. So if the length is too short, you will end up in definitely some amount of velopharyngeal incompetence, which you have to deal with it, some form of soft palate lengthening by means of a buccal mucosa flap or, uvuloplasties or whatever it is there. So these are some of the cases which, we have operated in, lengthening of the palate. I'm not going to go detail into it. Right. This man came to me, looks fantastic. He's a coolie worker. He has some lip deformity. When we opened the mouth, the palate is not operated. Okay. And one of my fellow was operating about 4 or 5 years ago, if I remember very well. And initially it looked fantastic. It looks healed. She raised a very nice flap, healed very well. It looks nice, immediate post-operative. Then we had a trouble. Look at it. It looks so good initially to start with. Immediate post-op, very nice raised. For some reason, because of ischemic change, because of, I don't know whether it is the vascularity was compromised, or is it because that it is wide cleft palate, that we lost both the flap in the anterior 2/3. We lost both the flap. And we ended up in having such a huge fistula there. So this is something which can be expected. We again went for a revision palatoplasty. 4 months post-op, again it's a problem. Well, you can see here, whatever the amount of mucosa remaining without a ruga here, it's all the scarred palate, which is very, very difficult. The next stage, we did a tongue flap foring. You can see the first layer, mucosa, the palatal mucosa, sorry, the nasal mucosa, then the palatal mucosa. Very unfortunate. Third attempt failed again. Sometimes you can have, if one complication start, it will be like a chain of things. It can go from one to another and you will end up in problems like this. Okay. Fourth attempt, we did try causing best for the same patient by using a facial artery based myomucosal flap. Okay, fourth attempt. More or less closed, apart from the small area what was remaining in the anterior. I think, if I remember very well, the last case that we did a labial flap and tried to close this, I think that was complete. So it took about 5 attempts for me to close the entire cleft palate in this case. It's an adult patient, not much of an issue. One small mistake during surgery can produce hell of a difficulty for operating this type of patients. Okay. I already told you severe dissections of the lip and the palate and other secondary surgeries can produce hypoplastic maxilla. Okay. You can see the maxilla is completely retrograde and we operate them and bring it forward. Okay. And post-operative, I don't want to discuss much about it. Just completing this thing, that hypoplastic maxilla. And one of the technique what we do nowadays is that instead of bringing the whole maxilla forward, we do only the anterior maxillary distraction, AMD, what is called as the AMD. That means only bring the front of the maxilla instead of the whole leaf foot one segment. It's called as anterior maxillary distraction. Sometimes it looks fantastic. You can see the whole midface has come forward. It looks very good. But you may probably get some small fistula or something in the process. But otherwise, the process is very good. You can also expect severe cases of mandibular retrognonism, including some other patients as well. You know, with incompetent lip, and we have done a distraction in this patient, severe bed faces. Okay, we did distract. We put an extraoral multiplanar distractor in this case. Looks fantastic. I had a tough time because I lost one of the teeth in the process of breaking the mandible. Okay. On the 10th day, we found the pus is pouring from one of the side. And we found that there is, growing some organism, some simple organism, antibiotic started. You can see that, the pus, how that. So you can expect problem like this as well, in cleft lip and other this thing. This is something syndromic, for example, you can expect hyperplasia because of or unilateral issues, asymmetries. Okay, if not looked after properly, even after looking after a child which was looked after from the age of 7 to 23, you can see that the process. Most of these patients in the cleft lip, have been following them since probably 2000 for the last 20 years. Same center, we have operated nearly about 10,000 surgeries. We have seen enough and more difficulties of operating, and because of the complications, so many things. We had to fight with the patient to get the proper, issues to get corrected. This is one of the patient, not done by me, but just a complication I wanted to include it. The patient had actually a costochondral graft placed for the cleft lip and palate patient. Also had issues with the mandible. So they had put you can see in the arrow, they put a costochondral graft. And in the costochondral graft, you can see a large, enlarged chondral part, which will grow, pushing the glenoid into the brain, almost into the brain. Then we had to correct that and, do a small condylotomy and procedures like that and to make it normal. This baby I operated in 2000. Okay. I just wanted to say that sometimes we have to keep fighting to reduce the amount of complication in patients. That's how I was in 2000 when I came back from UK. Same baby, the parent still holds that photograph in their hand. So I said, okay, give me that. I just want to take a picture of that and put it. The baby was hardly 1 year old. This is about 13-year-old. You see that from there, we tried to correct a bit more of scar. We ended up in having what is called as severe scar, something equal to hypertrophy or, and again, after this hypertrophy correction have to be done by taking a abbey flap, unilateral abbey flap, and correct it. But patient has midface deficiency, and length of the lip is a problem. A lot of issues that. So we ended up in I'm following it up this patient for last 21 years now. 21 years, from a 3-month-old baby to now. We have a lot of setback in management of cleft lip and palate. It is not like whatever comes in our hand can made into 100% perfection. You can have difficulties, you can have complications. This baby we operated when she was about 9 months old. Severe tessier cleft running from lip to nose to eye, and that you can see that the difficulty in reconstructing the lower eyelid immediately. This is immediate post-op. Now the patient is like this, having only about 40% vision, because she already lost that the corneal part of it. There are a lot of issues that we are facing still in managing these patients, and this patient also I've been following it for quite a long time. And of course, already mentioned by our previous professor speaker that about the rhinoplasty. So if not for cleft lip and with the primary rhinoplasty, you have to do a secondary rhinoplasty and correct this. And when we're doing the secondary rhinoplasty, simultaneously one have to do a little bit of lip correction as well in order to get a better. You can see that the lip and the nose is corrected in one stroke, because this is probably the last thing that one wanted to do it in order to get the best of the possibilities to reduce the complications in this type of patient. So thank you so much, and I think that's what I don't want to much. I have it, so I just want to put it and say that it is always a difficult situation that when you are operating thousands and thousands and thousands of patients, you will get a lot of bad result as well. It is up to you to get that into the right way to do with it. Thank you.
May I say something?
Thank you, sir.
Yeah. I personally would like to thank Dr. Manikandan to bringing out those complications.
Thank you.
Not many are comfortable in talking about the complications. Only those who have done many are okay with it, because everybody gets complications.
That's what I said, sir. When you're operating in thousands and thousands and hundreds, not everything goes right.
Yes.
You get bad results. You have to be prepared for plan A, plan B, plan C, and plan D as well.
Absolutely. Absolutely.
Excellent presentation, sir. It was very nice.
I have a question for Dr. Alva. Dr. Alva?
Yes, I'm here, Dr. Mohan.
Yeah. You talked about silicone and Botox for hypertrophic scar.
Mm-hmm.
Can you elaborate on that? What's your protocol for Botox and how does it act?
Actually, I only talk about it, doctor, but I have no really experience with these Botox and these silicone. I just only mention some of which kind of a hypertrophic scar we can use, for example, like laser and so on. Yeah.
Okay. Thank you. Thank you.
But apologize, I am not
okay. No problem. No problem. Jayant?
Yeah. Can we take some questions?
Dr. Bora would like to take some questions.
Are there any questions? In Dr. Manikandan's talk, Rashu, he showed a case of Eller retraction. Hello?
Yeah.
Eller retraction was shown in Dr. Manikandan's talk. What was his protocol to take care of it?
Can you, sir? I didn't hear it. Sir. I'm sorry.
One case which you showed had Eller retraction. Ala retraction.
Yeah.
Yeah. How did you manage that?
I don't remember now which patient is that. Is it?
I think the second last one. Not the girl with the clefts, say clefts. The other person which had a severe alar retraction on the right hand side.
Okay. So is that part of the rhinoplasty, sir?
Yeah, part of the rhinoplasty.
Okay. So I think as it's been already discussed, I think one is that the dissection part of it has to be 100%. And rhinoplasty is something which the master is very difficult, especially the cleft rhinoplasty, sir. And I have always found, compared to the cosmetic other rhinoplasties like hump reduction or the tip reduction, cleft rhinoplasties are very, very difficult. That is why always I always say that there are a lot of argument for and against it. Nowadays, in fact, most of the cleft surgeons are actually doing the primary nasal correction along with the lip corrections. And if you have a severely deformed nose, which is the columella issues and the septal issues and the alar cartilage hanging, and it's going to be a very tough job to do it. So there's no doubt that getting that symmetry is not going to be that very easy as well, but it is going to be very, very tough to do it. You need a total. I always say that specifically in unilateral cleft lip patient with a cleft palate, there is no something called as rhinoplasty. It's always septal rhinoplasty.
Yes.
Because septum is always in trouble.
Yeah.
There are issues of breathing. I always make sure that I always join with my ENT colleague for correction of the septum. I have to be very frank with it. We have to use the scope and make sure that it's been 100% the septum is maintained in the midline. And because I think most of the septal rhinoplasty have to be directed towards not only just the cosmetic part alone, but very important, 99% of them will tell about there's a functional issue as well, breathing. And that has to be corrected.
Yeah. Thank you. Would the Brajendra would like to talk on this or comment on this?
I think he's not there.
You're not? Okay, fine. No problem.
You want to say something?
No. I'm okay with it. Rashu wanted to ask a question.
Today is Dr. Gaurav and Dr. Parit. I think they are masters in cleft surgeries. So,
okay.
Yep.
Mani sir is there, so we need not to speak much about it. We all have learned from him directly or indirectly a lot of things. And we are always in touch, learning so many new things. And we always share our experiences. But as he said, that's very true. Septum has to be addressed along with the cleft rhinoplasty. And one thing which I have realized is when you get very good cartilage from the septum, which is utilized for a lot of alar augmentation or columellar strut or something like that. So if you are correcting the septum, at the same time, you can harvest some cartilage from the septum, from distal superior part, and that can be utilized. So you are actually doing two jobs, getting a good cartilage graft also and correcting the septal deviation.
You can do both, correct. But if there is a question of the dorsal augmentation along with the tip support,
then
one may probably end up in taking a cartilage graft, sir.
Yes, sir.
No doubt. I think that will be the best, no doubt about it.
Yes,
at present, though, if there is a reservation for the patient to take a rib graft,
always.
A synthetic one, but then I think there's nothing like taking a rib graft and.
Yes, sir. Autologous is always best. Rib is much better.
You can carve the shape and you can take a large piece of a cartilage graft and you can use it in for different for the dorsum, for the tip, and support, columnar support, and so many things it can do. I'm a big fan of cartilage graft, to be very frank. I hardly use the synthetic graft. Hardly use it.
Past many
years, septal rhinoplasty means I always take consent for cartilage graft.
Right.
Parit here. How are you, sir?
Hi, Parit. Can you be a little louder? We are not able to hear it.
Now can you hear me, sir?
Yeah.
Yeah. Excellent, encouraging talk, sir. And everyone has a complication. And as you said, if you stick to principle, maybe you come over all the complications. I have one question, sir. As you said, if you do extensive dissection during your primary surgeries, you will end up with maxillary hypoplasia in some case. So I just want to know your view on subperiosteal versus supraperiosteal dissection during primary lip repair.
I always, when I started my career 20 years ago, I always did subperiosteal for the lip, and for palate you have no choice, of course. For the lip, always subperiosteal. But now I stick to supraperiosteal area and a minimal dissection as possible. So rather than that severe dissection necessary, the past everybody thought that nothing all this will come into position unless you really dissect towards infraorbital area, towards the side. I think that concept is slowly gone now. Nowadays, what probably a cleft surgeon think is that you raise a nice composite flap with minimal, supraperiosteal dissection. And if we can get the things into the right place, now we have, very good nasoalveolar molding techniques, and people are trained in it. So there is no reason why we have to do a radical dissection towards the nose and towards the zygoma, towards the maxilla. And all this can bring about. And again, I said, if we are doing more and more and more and more in the childhood, you will end up in producing more scar. And the more dissection you do it, the more surgery you do it. I found in my last 20 years of career, the chance of getting a hypoplastic maxilla is extremely high. I still suggest, after 20 years of experience, now I strictly go on with supraperiosteal dissection rather than a subperiosteal dissection for lip.
Yeah, thank you very much, sir. Yeah.
Any other questions?
Yeah, I have a question for Dr. Alva. Yeah,
Yes.
just see. Yeah,
Yes,
you
okay.
discuss about lip. Yeah. Yeah, you discuss about fat grafting for lip augmentation in cleft patients. So, in my experience, I feel wherever there is a scar, you get bulging at the side of the scar, and on the scar, you feel you get some notching. So, how do you address that?
For notching, for example, like what I show in the slide, I usually do the wedging. But depends on the scar on which place. But there is a notching, I will usually wedges and then close it directly. Only that's a very simple surgery.
No, I'm asking about fat grafting. When you do fat grafting in a cleft, suppose unilateral cleft, and when you do fat grafting, so fat doesn't go at the line of scar. Instead, it goes side of the scar.
You mean the fat grafting?
Yes.
Okay, the fat grafting, I usually use these dermal fat, usually from these buttocks. And then after I incise the epidermis, I put it inside and I open up all the scars and just put it inside with the graft. Should be going.
Okay, thank you very much. Yeah.
Can I just add on to that, Dr. Parit?
Yes, sir.
Yeah, what normally I tend to do is that I use the dermis fat, when you're taking a bulk of dermis fat graft, that notch area, wherever there's a scar, you get rid of the scar first. The problem is having a notch with a scar. You can remove the scar, removing whatever the lip, that notch is there. You put this and try to get a brand new area. So I always make a cut in the notch, then pass the fat onto either side. It is not a free fat injection. I'm talking about a dermis fat graft.
Right.
So otherwise, as you said, in the scar area, it is always a problem. There's no doubt about it. Because it doesn't allow you to expand the scar in that area, the lip in that area. So if I am putting a fibrofatty bulk like that in the area of the lip, I always tend to cut the area of the scar, get the notch corrected, then pass it on to the set and get a new lip, stitched onto that area.
So, sir, your area, so your area of access is through the scar revision side, not from the side.
I do
right?
both the time. I start from the angle here, then make a cut here, then make a cut here in the area of the scar. So it is 3 areas I do.
Okay. Thank you, sir.
This is for a fibrofatty graft, not for a free tissue, not free fat injection. No.
And how do you manage free fat injection, sir?
I have hardly done it for a cleft lip and palate patient. If at all, probably one have to do it by taking it from the abdomen or something like that. But as far as I'm concerned, my results with the thickness of the graft, because I found there is a lot of number of patients for the thickness, I always found better with fibrofatty block graft rather than micro injection.
So compared to dermal grafts or fascia, we are taking a fascia and make a roll and
I take a dermis pad. I always take a dermis pad. Because to get that consistency, it should appear like a lip. So, within 6 months' time, it does wonderful job.
There is a question in the question answer. What about wrapping in rib cartilage for cleft rhinoplasty?
Yeah, one can always get it. Of course, if I think one of the faculty was speaking.
Bajendra sir.
Sir is still there?
Yeah, you can talk.
No, yeah, it's quite difficult sometimes. That what we can do is that what we tend to do is that don't put it immediately. I always take a graft, carve it, wait for some time and put it in saline and wait for about half an hour to 45 minutes. See whether there is any warpage and redo it again. Carve it again and do it. So it's something which is very difficult to predict whether it's going to warp or not. That is something which is not in our hands sometimes. Only thing what is very important is that your carving have to be 100% and at least put it in saline for at least about 45 minutes to 1 hour before you go for the replacement. So once I decided, okay, I'm going to go for a cartilage graft. The first thing is I take the graft and first carve it almost to the, close to the size of it, leave it in the saline for about 45 minutes to 1 hour. Then take it out and see what happens, whether it is, warped or not. Again, do for a small revision and put it back. So otherwise, it is going to be very, very difficult to predict for anybody whether it is going to warp or not. Very difficult. I don't have any technique to say that it will never warp.
Any other questions to take on? So, thanks a lot, sir. It was actually, in fact, the competition was really nice. The way you took the presentation was extremely good, And as everyone said, it is because of volume and our experience, you could have able to put it in a very nice way. Really thank. And Sir is also our Isfaro National Advisory Board for our Isfaro. Thanks, sir. Thanks a lot for being there. On behalf of Isfaro, I thank all the speakers for giving excellent academic feast and good discussion. I thank the moderators and our Isfaro team. I thank our academic partners, Microlab, Praveen, Shuhash, and Savitri Madam. On behalf of Isfaro, we will see you all next Sunday, that is on 31st Jan, which will be the 5th and final session on Craniofacial webinar series. Thank you, sir. Thank you all.
Thank you. Thank you. Thank you very much.
Thank you. Doctor. Thank you, doctor.
Thank you. Thank you, everyone.
Thank you.
Very nice. Very nice. Thank you.
So I will end the session now, Dr. Jain, sir.
Yeah, you can end that. Thank you.